Good morning, ladies and gentlemen. So it really is my pleasure to provide an update on hypophosphatasia and how do we diagnose and manage hypophosphatasia today. I have received research funding from a number of the industry partners for the development of new molecules for metabolic bone disease and parathyroid disease. And these are listed here on this slide. So I do want to begin with a case. We have recently seen a 53-year-old man who presented with bilateral stress fractures. And this was with a fall from standing height. He had to have rods inserted. And prior to the fracture, he had thigh pain for 5 months. There was absolutely no prior anti-resorptive therapy that he had been exposed to. He also had not been on PPIs or steroids. He's 53 now, and a year before, he had a left ulna fracture with a simple fall. Of note, he had lost his primary teeth at the age of 2, and he also had generalized bone and muscle pain that he was complaining of. He did have a history of hypertension and dyslipidemia. He was taking vitamin D. He was also on a perindopril and a torvastatin, and his examination was otherwise unremarkable. So let's talk about hypophosphatasia, because this was his diagnosis. And what is hypophosphatasia? Well, it is a condition where we have abnormal mineral metabolism, which affects multiple organs. And it is due to loss of function in the alkaline phosphatase gene. And this encodes tissue non-specific alkaline phosphatase, which is richly expressed in the liver, in the bone, and in the kidney. And at this time, we are aware of more than 300 different disease-causing mutations which have been reported. And the condition can vary from being a very mild condition to being lethal. Remember that in the adult, half of the circulating alkaline phosphatase is bone and the other half is liver isoforms. And tissue non-specific alkaline phosphatase dephosphorylates many extracellular molecules. The three major substrates are inorganic pyrophosphate, pyridoxal 5' phosphate, and phosphoethanolamine. How common is this condition? Well, fortunately, it is not a common condition. It is a rare bone disease. And in Canada, we're looking at about 1 in 100,000, but there are certain populations, such as the Mennonite population, where the prevalence may be 1 in 2,500. And so there's a large Mennonite population in Manitoba, and also in Hamilton, we do have a fairly significant Mennonite population. And in this population, we do see a higher prevalence of HPP, and it could be 1 in 2,500. So when we have this reduction in alkaline phosphatase, which is a cell surface enzyme, what will happen normally is that tissue non-specific alkaline phosphatase cell surface enzyme will dephosphorylate inorganic pyrophosphate. And it will result in the release of 2 molecules of phosphate, which will then bind with calcium to form the hydroxyapatite crystal that will mineralize the skeleton. Now, if we have inadequate levels of tissue non-specific alkaline phosphatase, then inorganic pyrophosphate will accumulate. And we will have an abnormal ratio between inorganic pyrophosphate and phosphate. And calcium is not able to bind to phosphate and enter the skeleton because inorganic pyrophosphate inhibits bone mineralization. And so calcium levels will rise, and this can go on to suppress PTH. And the manifestations of this condition are elevations in calcium because it's not entering the skeleton. It is not able to mineralize the skeleton, mineralization abnormalities in the bone, and mineralization abnormalities in the periodontal ligament and the cementum, so that teeth can come out with the root intact in early infancy. By age 2, these children will have lost their primary teeth. The bone is not mineralizing, so it's resulting in rickets, which can then result in bone deformation. And it's also associated with a significant myopathy, which is really quite striking. So we do have accumulation of these substrates: inorganic pyrophosphate, pyridoxal 5' phosphate, and phosphoethanolamine. And the phosphate can also rise, as it is not binding with calcium to form the hydroxyapatite crystal. And we can see elevations in serum calcium, and we can also, that will suppress the PTH, and low PTH can therefore result in rises in phosphate. Remember that PTH has a phosphaturic effect, and so if we have suppression of PTH because of elevations in calcium, then we can have rises in phosphate actually. And vitamin D is usually normal, but it may be low in the adult patient with hypophosphatasia. Pyridoxal 5' phosphate, PLP, is the circulating form of B6. And we know that tissue nonspecific alkaline phosphatase is involved in the development of the central nervous system. It will dephosphorylate PLP and result in the release of pyridoxal. And this will then cross the blood-brain barrier and become rephosphorylated. So it is pyridoxal, not PLP, that crosses the blood-brain barrier and enters the cells and is again rephosphorylated to become PLP. And PLP is an essential cofactor in neurotransmitter synthesis. So serotonin, dopamine, epinephrine, norepinephrine, GABA, all of these require PLP. And so what happens in patients with HPP is there is altered B6 metabolism, and this can result in seizures. An administration of pyridoxal does not end the seizures, but they do respond to B6 administration. What about phosphoethanolamine? So we talked about inorganic pyrophosphate accumulating, preventing the mineralization of bone and dentition in the teeth. And we talked about PLP and the manifestations with respect to seizures. What about PEA, phosphoethanolamine? What are the manifestations of having excess amount of this substrate? Well, this accumulates and it can inhibit mitochondrial respiration, but the role of PEA is not fully clear at this time. But we feel that it may be the cause for the significant myopathy that patients with hypophosphatasia manifest. It can also serve as a diagnostic marker of the disease, but the exact metabolism is not clear at this time. So we can see that hypophosphatasia results in multi-organ impact. It can result in osteomalacia in adults because the bone is not mineralizing, and patients can present with recurrent fractures which are not healing. Metatarsal fractures can happen, like our patient presented with atypical femoral fracture, stress fractures of the femur. This patient had bilateral stress fractures of the femur. A significant skeletal abnormality is present in the presence of hypophosphatasia. And in children, this presents with rickets. The rheumatologic manifestations also include calcium pyrophosphate crystal deposition in the joints, and patients can have pseudogout and present with bone pain. They can present with arthritis in the knees. So it is important for us to evaluate the joints. We're looking for pseudogout that may be present as a manifestation of HPP. Remember that patients can have nephrocalcinosis because phosphate can be elevated, calcium can be elevated, and they can be ectopic calcification, and patients can develop nephrocalcinosis, which can then go on to result in renal impairment. Patients that can have neurologic manifestations in HPP because PLP is essential for GABA synthesis. So there is defective GABA metabolism, and patients can have seizures which do respond to vitamin B6. And then there are the dental manifestations with impaired cementum mineralization, impaired mineralization of the periodontal ligament, and loss of the alveolar bone, and enlarged pulp chambers. So the presentation is really a reflection of the fact that the bone cannot mineralize because of accumulations of inorganic pyrophosphate and the change in the ratio between inorganic pyrophosphate and phosphate. But there is a significant heterogeneity in the presentation, and this depends on the type of mutation and also the age of presentation. And if we look at symptoms, we can see that 68% of patients will be symptomatic, but there is usually a large delay between the onset of the symptoms and the diagnosis of the condition. And the reason for this delay in the diagnosis is because people are not aware of hypophosphatasia and they're not thinking about hypophosphatasia. And unfortunately, these patients will go on to experience many complications from hypophosphatasia and also receive inappropriate drug therapy, such as bisphosphonates, if they're diagnosed with osteoporosis. How commonly will patients experience these complications? Pain is a common manifestation of hypophosphatasia, fragility fractures, 86%, muscle weakness, 62%, and 60% of patients will require gait aids. The fractures can be poor healing. They can develop stress fractures, metatarsal fractures, and subtrochanteric fractures. So we talk about metatarsal fractures as not being fragility fractures. But if our patient is presenting with recurrent metatarsal fractures, it is important for us to consider that they may have a rare bone disease and review the alkaline phosphatase levels and go over the history in further detail. Did they have premature loss of the teeth with the root intact? Do they have muscle weakness? Do they have chondrocalcinosis? Do they have pseudogout? Review the spectrum of the disease presentation. Remember, there's psychologic manifestations as well, such as anxiety, depression, pain, and this is important for us to evaluate. What is the bone density like in patients who have hypophosphatasia? Well, it could be low or it may be normal. But a normal bone density is extremely rare. There was a case study of a case series of 14 patients, and the bone density was usually low or in the osteoporosis category. None of the patients in these 14 patients had a normal bone density, but we do have a patient with a molecular diagnosis of HPP who has a normal bone density. And we believe that, the thickened osteoid may still be captured in the DEXA assessment, and it can result in a false overestimation of the bone density. So the bone density could be low, it could be in the osteoporosis range, or it could be, as in one of our patients who has a confirmed molecular diagnosis, it could be normal. If our patients are experiencing fragility fractures, it is important that we recognize they do have impaired bone strength and confirm a diagnosis of the increase in the fragility and the presence of impaired bone strength. They could have idiopathic osteoporosis, or they might have osteomalacia. And the degree of the two conditions can coexist, and we might need a bone biopsy to tease it out. If you have a postmenopausal female who also has underlying HPP and she has a fragility fracture, is this because of postmenopausal bone loss, or is this because of osteomalacia in association with her HPP? And to determine which component is more significant requires a careful history and physical, and may require a bone biopsy. But in patients who have HPP, it is important for us to make sure that we do not miss this diagnosis, because bisphosphonates are contraindicated in HPP. Atypical femoral fractures are more frequently seen in individuals with HPP. Bone biopsies from the iliac crest do demonstrate the presence of osteomalacia, and calcium pyrophosphate crystal deposition in the articular cartilage and around the joint results in chondrocalcinosis and pseudogout. And patients can develop nephrocalcinosis, as we mentioned, because they do have a secondary decrease in PTH with rises in serum calcium. They develop hypoparathyroidism secondary to the hypercalcemia, and this can result in elevations in phosphate. And the calcium phosphate can deposit in the renal parenchyma and result in nephrocalcinosis, and this can progress to renal impairment, unfortunately. So we've reviewed some of the skeletal manifestations. They may present with fragility fractures or simply low bone density, or a bone density which is in the osteoporosis range. In childhood and in infancy, they can have rickets. They can be bowing of the legs as they're weight bearing on bone that is not mineralizing normally. The fractures can be recurrent, they can be slow to heal, they can have bone pain, they can have joint pain, they can be poor growth, and they can also have craniosynostosis, so early closure of the cranial sutures. The skull bone, the skull itself could just be so poorly mineralized that it's simply a membrane over the brain. And it's really a protective mechanism that there's early closure of the sutures to protect the brain. But if this happens, then patients can get rises in intracranial pressure, and it can result in further neurologic complications. The proximal myopathy is really quite striking. And we do see patients who require gait aids. Adults can require gait aids, might require a wheelchair. The muscle pain can be quite dramatic as well. And in infancy and in childhood, there will be a delay in motor milestones. Patients can have joint pain and the chondrocalcinosis that we've discussed. The renal complications we've mentioned, patients can have elevations in serum calcium and secondary hypercalciuria. This can be associated with an increased risk of stones and impairment in renal function. And we've talked about the dental manifestations, but also the teeth will have an abnormal shape, color, and structure, and they can also be periodontal disease as well. And so the loss of the teeth is because of a mineralization defect in the cementum, with premature loss of teeth with the root still intact. And the neurologic manifestations include seizures, as well as the increased intracranial pressure due to premature closure of the cranial sutures. And in a retrospective chart review of 82 patients with hypophosphatasia, which included adults and children, skeletal manifestations are present in 89% of these patients. 77% had dental complications. The myopathy and the muscle weakness was present in 66% of patients. Fatigue, 66% of patients, and non-specific symptoms of headache was seen in 66% of patients. Now, in infancy, patients can have respiratory failure. The babies can require mechanical ventilation, and this is because of the muscle weakness, the impaired mineralization of the chest wall as well. And patients can have rib fractures. And the myopathy is a significant component resulting in respiratory failure. And infants with severe disease do require ventilator support. In adults, we've mentioned the metatarsal fractures, subtrochanteric fractures. Patients can have pseudofractures of the femurs, and they can be poor fracture healing. Patients can have the chondrocalcinosis with calcium pyrophosphate crystals depositing in the articular cartilage. And they can also present with the renal complications with nephrocalcinosis and renal insufficiency. The bone density, as we've mentioned, may be low. It could be in the osteoporosis range. It is important that before we start treating a patient with osteoporosis that we review the alkaline phosphatase. This is absolutely critical. If it is elevated, we need to know why it's elevated. We need to fractionate it and confirm if it is skeletal or hepatic. If it is low, however, we need to find out why the alkaline phosphatase is low and ensure that we are not missing a case of hypophosphatasia, because bisphosphonates are contraindicated in a patient who has hypophosphatasia. As we know, bisphosphonates are analogs of pyrophosphate, and they can further exacerbate the mineralization defect. And they may increase the risk of atypical femoral fractures. So when we make the diagnosis of hypophosphatasia, it is a clinical diagnosis in the presence of a low alkaline phosphatase. That's how we make the clinical diagnosis. Based on the signs and the symptoms, it is supported by a persistently low alkaline phosphatase adjusted for age and gender. And then we can go on to get a molecular confirmation of that diagnosis. But the diagnosis of HPP is a clinical diagnosis confirmed. You can do a molecular confirmation with a DNA analysis, but it is supported by a persistently low alkaline phosphatase. And there are many reasons for a low alkaline phosphatase, and we need to ensure that our patient does not have one of these reasons for the low alkaline phosphatase. So are they on anti-resorptive therapy? Are they taking excess vitamin D? Check the vitamin D levels, the 25 hydroxyvitamin D. Have they received chemotherapy? Any severe illness can result in a reduction in alkaline phosphatase. Have they had major surgery or trauma recently? Have they had massive transfusions? Blood transfusions can be associated with reductions in alkaline phosphatase, as can nutritional deficiencies. And then there's certain diseases that are associated with reductions in alkaline phosphatase. And this includes hypoparathyroidism, where the bone remodeling is reduced. It includes hypothyroidism. It's important for us to evaluate parathyroid function as well as thyroid function. We need to look at renal function. Remember, renal osteodystrophy, patients may have adynamic bone disease. In one of the types of renal osteodystrophy, we need to make sure that our patient is not in one of those categories. Achondroplasia can be associated with low alkaline phosphatase, as can Wilson's disease and myeloma. We can go on to do DNA analysis of the alkaline phosphatase gene, but it is not essential to have a molecular confirmation of the clinical diagnosis. But it is nice to have that molecular confirmation. Okay, so let's move on. I will be referring to our Canadian update on the diagnosis and management of hypophosphatasia. And we did an evidence-based review and made some recommendations. We do have limited evidence, and we published this just last year. So if we look at hypophosphatasia, we need to recognize that there may be other diseases that can look like hypophosphatasia. We talked about the importance of ensuring that there is no other reason for a low alkaline phosphatase. In the other conditions that can look like hypophosphatasia, we see elevations in alkaline phosphatase. For example, in rickets, alkaline phosphatase is elevated. In XLH, alkaline phosphatase is elevated because there is abnormal mineralization of the skeleton. Osteogenesis imperfecta, the alkaline phosphatase is normal. In Paget's disease, the alkaline phosphatase is elevated. PLP, one of the substrates of tissue nonspecific alkaline phosphatase, PLP is elevated. Serum calcium, it could be elevated or it could be normal. And in nutritional rickets, it's low because it's not being absorbed. In XLH, calcium levels are normal. In OI, it's normal. In Paget's disease, it's normal. Phosphate can be elevated because of the hypoparathyroidism that results secondary to rises in serum calcium. PTH is going to be suppressed and phosphate may go up, or it may be normal. In nutritional rickets, phosphate is low because we're not absorbing calcium from the bowel. In XLH, that is the underlying problem, and that is that phosphate is low. In osteogenesis imperfecta, phosphate is normal, and in Paget's, it's normal. And with hypophosphatasia, PTH may be suppressed because of the hypercalcemia, or it may be normal. In rickets, PTH is elevated because of the deficiency in vitamin D. Serum calcium is low. It's going to be sensed by the calcium sensing receptor on the chief cells. You see rises in PTH. In XLH, PTH is normal. In osteogenesis imperfecta, it is normal as well. I will say that in XLH, we can see rises in PTH subsequently, and this will be addressed in our subsequent presentation, where we will provide further detail regarding this. In Paget's disease, we can see elevations in PTH as well. Vitamin D in hypophosphatasia is usually normal. And if it's not, it's because the patient is not taking enough vitamin D, and we need to ensure that they are normal. In rickets, the vitamin D is low. In XLH, the 25D may be low, or it could be normal. In OI, it is normal. And in Paget's disease, it could be anything, and it just is based on how much vitamin D the patient is taking. So the management of hypophosphatasia in adults includes normalizing vitamin D. We need to ensure that 25 hydroxyvitamin D is normal. We do not give 125D because it may increase phosphate further. We do treat the underlying bone pain. We want patients to be exercising so that they can improve muscle mass. We want them to be seeing their dentist frequently so that they can have appropriate intervention for their teeth and ensure that dental hygiene is optimized. Consider orthotics if they're having recurrent metatarsal fractures. Avoid bisphosphonates. They need to ensure that bisphosphonates are not given because there is a mineralization abnormality, and bisphosphonates can further impair skeletal mineralization. So anti-resorptive therapy may further lower alkaline phosphatase, which is already low. And we want to ensure that we're not giving bisphosphonates. Also, giving denosumab may make the situation worse because it will further reduce alkaline phosphatase levels. Excess vitamin D can contribute to further elevations in calcium and hypercalciuria. And if the phosphate is high, think about phosphate binders. If your calcium is high, you cannot give calcium as a phosphate binder, but you might want to consider sevelamer as a phosphate binder if necessary. Now, what are the treatment options for patients who have hypophosphatasia? Well, PTH 1 to 34, we do have published case reports suggesting improved bone pain, fracture healing, and bone density. Another case report, PTH had no effect on bone density and fracture healing. So the data is inconsistent. We do not have any controlled trials for PTH in hypophosphatasia, and we have limited data when it's inconsistent and conflicting. Calcitonin has been attempted without improvements. There is a trial looking at an anti-sclerostin antibody in hypophosphatasia. So we can now give back recombinant human alkaline phosphatase in the form of aspartase alpha. And this will provide enzyme replacement therapy for patients with hypophosphatasia. And this is a bone-targeted human recombinant alkaline phosphatase fusion protein, which will replace the enzyme activity at the site of the deficiency. And the structure of aspartase alpha, we have the alkaline phosphatase domain, and it is linked to a human IgG Fc domain, which is linked to a decapeptide, which allows this molecule to attach to the bone. And it has a 32-fold greater affinity to purified hydroxyapatite. So we're now able to provide the aspartase alpha will be able to replace alkaline phosphatase at the cellular level and treat the underlying cause of hypophosphatasia. Sorry. And we are able to then break down inorganic pyrophosphate, hydrolyze it so that we are able to release phosphate, which will then bind with calcium and allow the mineralization of bone with the formation of calcium phosphate, the calcium phosphate hydroxyapatite crystal. What is the evidence with aspartase alpha? Well, this was a study that was looking at 11 patients in a phase 2 open label study. The children were under 3 years of age. 10 children completed 6 months of therapy. 9 completed the full year, and alkaline phosphatase levels rose, and the substrate levels declined with reductions in PLP and inorganic pyrophosphate. There were improvements in bone mineralization, and this was evaluated and recorded with radiographic global impression of change. Pulmonary function improved, physical function and development improved, and continued therapy out to 3 years showed ongoing improvements in bone mineralization. So who should we be treating? We need to treat individuals who have osteomalacia, who have complications of osteomalacia. We need to treat people who have pseudofractures. We can now give back the enzyme that is missing and allow the inorganic pyrophosphate to be dephosphorylated and to be hydrolyzed so that we can relieve the mineralization defect which is present on the bone and allow the bone to mineralize. We can also see improvements in musculoskeletal pain, which previously was unresponsive to opioids and requiring significant analgesics to relieve this pain. So giving back aspartase alpha can result in improvements in musculoskeletal pain. Patients who have significant chondrocalcinosis could also benefit from this. Certainly patients who have had major osteoporotic fractures or who have had delayed healing of stress fractures. These are patients who will obtain significant benefit from aspartase alpha. Patients who have significant impairment in function with impaired gait and mobility will also benefit from aspartase alpha. So how do we follow these individuals? We can certainly look at the impact on muscle function, look at gait speed, look at mobility. On examination, is there evidence of bone tenderness? We can do ultrasounds of the kidneys and look at nephrocalcinosis. We can look at renal stone formation. We could also look at ensure that patients have an assessment by an ophthalmologist to ensure that there is no evidence of ectopic calcification. The bone density assessment is of value. We can do quality of life questionnaires, assess pain control, and evaluate their response in terms of their ability to do activities of daily living. The study looking at aspartase alpha in adults and adolescents with hypophosphatasia showed that aspartase alpha can reduce the substrates significantly, and it can result in improvements in bone mineralization. And with the bone biopsies, there were decreases in osteoid volume. Improvements in walking were noted as early as 6 months, and these were also seen at years 1, 2, and 3. And 5 of the 19 patients were able to improve their gait and balance with reduction in the use of gait aids on therapy. So it is important for us to remember that enzyme replacement therapy has been approved for use in patients of any age with pediatric onset hypophosphatasia. And enzyme replacement therapy offers an opportunity for a normal life for a previously lethal condition. Remember that not all perinatal babies respond to treatment, and treatment failures have been reported. Monitoring guidelines have now been published for monitoring patients with hypophosphatasia. How do we access aspartase alpha? Public reimbursement is available only to children under the age of 18, and for adults, it is important for us to try and get this covered, and it is important for us to document the diagnosis. So the presence of muscle weakness, musculoskeletal pain, the presence of fragility fractures, all of these points need to be documented so that we can get third-party coverage for our patients. But we do need more prospective data looking at benefits of therapy with respect to improving the musculoskeletal outcomes in hypophosphatasia, and we do need long-term prospective data. What happens when we stop aspartase alpha? Well, 5 patients who participated in the study did not continue on therapy at the end of the study, and there was a significant deterioration in their motor function, and they had pain again, reappearance of pain. They required mobility devices which they had previously been able to stop. There were new poorly healing fractures in 3 of the 5 patients that had to stop therapy. And clearly this had an impact on quality of life, and mobility declined in all 5 patients following 1 year of cessation of aspartase alpha. So to summarize, hypophosphatasia is a rare inherited disorder of bone and mineral metabolism. The presentation in children and adults is variable. The diagnosis is often missed or delayed in children, particularly in adults. And this really underscores the importance of looking at the alkaline phosphatase level. If it is low, evaluate it further. We need to ensure that we don't miss this diagnosis. If we can identify the condition, then treatment can be life-changing. And enzyme replacement is now available for patients with hypophosphatasia. We will be coming out with updated recommendations as more evidence becomes available, as our knowledge of this condition becomes more detailed, and as we have further prospective data on the efficacy of drug therapy, we will be developing subsequent evidence-based recommendations as new evidence becomes available. So stay tuned. But our patient did have DNA studies completed and was heterozygous for a pathogenic mutation in the alkaline phosphatase gene. And this has been reported previously to be pathogenic for autosomal recessive hypophosphatasia. We were able to access aspartase alpha for our patient, and he has now started therapy. So, you know, we are able to intervene and make a big difference in the lives of patients with hypophosphatasia. So I would like to thank you for your attention and answer any questions that you may have.